patients and clinicians, they behave very differently. We know that from different studies. On the other hand, we have effectiveness studies, naturalistic studies, from the real-world setting, unselected patients, everyone can join, unselected clinicians, even though that hates different rating scales and treatment modules, and no exclusion criteria and no control group. What we struggle with is that we have a lot of clinical guidelines that are based on the efficacy trials, the randomized controlled trials. But the results from these efficacy trials, they are not very easily generalizable. It's not that easy to pick the treatment plan from the TUD study for depressed adolescents and get into the service system. At the same time, there's a low number of effectiveness studies, and it's really difficult to perform effectiveness studies. It's really expensive. So one way would be to use routinely collected variables. And CGAS is just one example. And we had CGAS, so it was natural to try to see what can we do with the CGAS rating. So this is the paper, Outcomes of Child Psychiatric Treatment, where we try to look at all the CGAS rating we had collected during 3.5 years. The aims were to investigate outcomes of child psychiatric outpatient treatment. No inpatients are included here, as measured by change in CGAS. And that is what we call delta CGAS, before and after treatment. And this is a large naturalistic cohort, so we had no control group at all. And the aim was also to identify predictive clinical factors for the change in CGAS. And I will talk more about mood disorder and ADHD, since it's our large clinical groups we have in our services. So we had 12,613 outpatients from this period. And the mean age was 12, 52% girls. Number of visits, 13. And the treatment period was more than 1 month. Now, if you remember that CGAS rating looked at the last month, so I'm very against performing CGAS ratings closer than 1 month. So I excluded all the patients that had a shorter treatment period than 1 month. We used the data from our clinical database, PASTIL. It includes information about the diagnosis. And the diagnosis is assessed depending on DSM-4 and or ICD-10. Just as you have, it's compulsory to report ICD-10, but most clinicians actually use DSM-4 because it's more friendly to use. If we use ICD-10, we need to go into the research manual, and people don't have the research manual in their room, so the diagnostic criteria in DSM-4 is actually used. CGAS rating at first visit and end of treatment, and then we have some treatment variables. We know if there has been some type of counseling or psychotherapy. We have information about the time frames, short-term or long-term. I mean, it's not very detailed. The settings, if it's an individual with a child or a group setting, or maybe the parents or the family. We also have some information about medication. We know if it's central stimulants or other medication than central stimulants. And we also have information about psychosocial stressors. There's a long list of the stressors. Death in the family, somatic illness, drug abuse, child abuse, lots of different factors that are listed. I thought, actually I worked a lot with this one because I think this is one of the problems we have, and that's about the rubbish data, and that we have lots of patients, but we really need to select the patients that have good ratings and correct ratings. So from this time period, 3.5 years, we had 44,000 registered patients. Now, immediately we excluded if the treatment period was shorter than 1 month. So 1/4 was excluded. And of course we also excluded all the patients that continued treatment. So sometimes it's kind of, oh, only 12,000 were included and they had 44, so many dropouts, but it's really important to look at why were they excluded. So we have 25,000 selected patients, but then we excluded another 12,000 patients. Now, if CGAS was 0, this is a situation when the clinician has decided, I do not have enough information to perform a CGAS rating. So it's not a dropout and it's not missing data. It is a clinical decision when we cannot perform the CGAS rating. We have 5,000 where there has not been a rating at all. Clinicians won't rate sometimes. I think we can work with this number a lot, so we can get it to decrease. If CGAS was 100 at baseline, we don't think they qualify to, and sometimes there are clinicians that do not want to stigmatize patients and they do not want to rate the lowest level. So we excluded them. If they were too young, under 4, or too old, over 20, they were excluded. Inpatients were excluded. And also CGAS 0 at case closure. Again, a group of patients where the clinicians did not think that they could perform the rating. And missing data at case closure. Just to see what happens with when you go from 44 to 12,613. Now, I know, Andy, you looked at the table. There's a long table here, and you can look at it in the thesis or in the paper if you look at the PubMed. I just picked out the group that improved the most. Suicide attempts have a delta CGAS of 16. Remember, only outpatients. Now, inpatients that really need a lot of supervision have an even lower CGAS than 43 at baseline, but they are not included in this material. That the suicide attempts were the ones that improved the most is not strange at all. Lots of anxiety, a crisis situation when you come after a suicide attempt. And if it's regression to the mean or the actual treatment that will make them better, well, that's something we can discuss. And the other end, we have mental retardation with an improvement of 3.9. Could you say that CAMS is really bad on treating kids with mental retardation? Or you can say, well, there is not much treatment effective for this group. They get their support in the school system and in training situation, more more pedagogical interventions, and not a treatment that counts. Mood disorders improves 13, and ADHD improves 6.5, and this is interesting as well. What I did was that I looked at all clinical trials with depressed adolescents and children that have used CGAS. What I could see was that the baseline CGAS was very equivalent to all the clinical trials. What we also could see was that the improvement of 13 was also very equivalent to the clinical trials. When I did the same thing with ADHD, it was not the case. The baseline for the ADHD group in our material is lower compared to clinical trials. So our group is more functionally impaired. What we also could see was that the improvement was much smaller compared to clinical trials. So in some way, we do not have the same group as they have when they look at clinical trials. And remember again the difference between efficacy and effectiveness. How generalizable are the results from a clinical trial? In this case, we could really see we do not have the same patients. maybe these are have more comorbidity, and they were really more functionally impaired. So this is a Todd's study. I usually take that one because it's kind of the Rolls-Royce study, at least this far. Maybe the impact study will be the next Rolls-Royce study in depressed adolescents. But just for you to compare, the baseline, 50, 49.5, 49.6, all the intervention groups, the combination of SSRI and CBT, the fluoxetine group, SSRI, the CBT group, and the placebo. So the baseline values here are almost identical to the results we have from the Pastille database. And also the improvement in the combination group, the best treatment group, they had an improvement of 16. Well, our treatment is treatment as usual. It should not be as a good improvement as this study. And for the medication, it's 12.5. The CBT group, it's 10. And the placebo group, it's a little bit over 10. So if you look at the results in this group, there was no difference between the CBT and the placebo. And the results here really supported the combination of CBT and fluoxetine. But it was interesting to compare the levels of the CGAS ratings with the clinical database that we had. So what we then did was to try to associate different clinical factors to see were there any clinical factors associated either positively or negatively to the improvement of CGAS. So this is the mood disorder. We have 2,213 patients. What we could see was that when you have a positive beta value here, it's a positive association. So what we did see was that lots of different psychotherapeutic intervention actually had a positive association with the improvement of CGAS. But down here was medication, and this was non-significant. And this really was a possibility for us to ask questions now. Who gets medication? Do they have a lot of comorbidity, or are there other explanations why we do not see a positive association in this group? This was also interesting. We had two factors that were associated negatively. One was counseling with family and social network. We have something that calls network therapy. I try to, at least in the US, they don't know what I'm talking about. But that's when we really gather the family and the community, and we have the therapy.
Team around the child.
Team around the child. So team around the child therapy. And we have special clinicians that are trained in this. And this was an intervention that was not positively but negatively associated.
I think it's more similar to family group conferencing, actually, than team around the child. Team around the
It's
child is not a therapy.
Okay.
Family group conferencing.
I think Anne's right.
What we're talking about.
Yeah. But this is a therapy. It's where you really work with. It's a huge group of people, and with the child and the parents.
And that's
Family
training.
group yeah, you have to be trained in it. It's called family group conferencing over here.
Oh, okay, okay. And the other, if the child is managed by others than psychologists, social workers, and medical doctors. And sometimes we have like only a nurse or something called treatment assistant. It's usually people with a lower education, and they are trained in clinical work. But it seems important that we also have team members that are psychologists, social workers, and or medical doctors involved in the case.
Would they be like our graduate psychologists, do you think, Anne?
No, I'm not sure we have such grade of people in this country. I know that does happen in other countries, not so much over here, maybe an adult psychiatry that's coming in, having sort of recovery work, isn't it?
Okay. It's kind of like nurse assistants that get a special internal training in how to manage cases, case managers.
Graduate, I think it's graduate mental health workers in the areas, which is mainly adults, not so much in childhood. It's something that's been explored in childhood.
Yeah,
it hasn't yet come in yet, so it's interesting.
People want to save money, so
Okay. So if we summarize the results when we look at the mood disorders, medication in mood disorder treatment were not significantly associated with improvement of CGAS ratings. And this differs from clinical trials. But several of the different psychotherapeutic interventions were positively correlated with baseline CGAS and with delta CGAS in the mood disorder group. And this is similar to clinical trials. And I think these results are interesting, and I'm curious about the impact study. I think that we have a lot of clinicians that are well trained in psychotherapy, and this group it's adolescent girls mainly, and they like talking psychotherapy, so it's not that strange. But we need to look into, are we medicating enough? Are we medicating the right kids? And what decides who gets medication and who does not? So it's... If we do the same with the ADHD group, now remember the ADHD group had a lower CGAS at baseline and less improvement in the CGAS. So here we have some intervention variables that are positively associated. Number of visits, managed by a medical doctor, parent counseling, and also therapeutic summer camp. Actually, it was interesting because Helen Minnis was opponent when I defended this thesis, and she had the opposite results of therapeutic summer camps. So we had a little discussion about that. But here again, a very difficult result that really challenged if this article would be published or not. So I really had to write, there were even reviewers that suggested take away everything about medication on central stimulants. It's almost not allowed to question the effect of central stimulants. But I will go into this a little bit further. But at least the result in this study showed that there is no positive association between central stimulants and improvement of CGAS. But there are explanations to that.
Sorry, can I just ask a quick question? Is the dependent variable the delta CGAS?
Yes.
So this could mean there's just no, children are still improving. It's just that using the central stimulus doesn't increase the improvements over what you get.
Well, that's a very good question. But since I excluded all the kids that continue treatment, so if you have a child that really improves and you continue the treatment, they are not included in the study.
But what I mean is the intercept in the model significantly above 0?
Yeah.
So if that's true, then even the kids who receive the central stimulus medication are still showing improvements. They're just not showing more improvements than the kind of average improvement. So it's about how you interpret the coefficients in the model.
Oh.
If the intercept is significant, but if it's maybe something to think about. So can you remember offhand how big was the intercept? Was it far away from you?
I don't remember that. I don't know. We need many more evaluations during the treatment period. So this really gave us concrete feedback. It's not enough to have in the beginning and in the end of treatment. And you could say like this: the ones that are still in treatment are the ones that do not improve, that are totally hopeless and we don't know what to do, so they just go into treatment and week after week after week? Or are they really improving and they just keep on getting their prescription and they get their support in school and everything is fine, and when they turn 18 they go into adult psychiatry. So that's another thing we need to look at, and so both ways are possible actually. So I think this group we're really curious on this group. What happens here when they are still in treatment month after month after month? So we would really like to add CGAS assessments every 3rd or every 6 months, so we could follow treatment.
That's what the MTA study showed, is that for ADHDs you got that improvement, didn't you? But it wasn't actually maintained, so it would be really interesting.
Yes, it really would. And what's so strange with the MTA study was, how could anyone think that they would maintain the improvement when they didn't continue the very fantastic, detailed treatment they had? Everyone returned to treatment as usual. So I never really figured that out, but it's interesting. First of all, we looked at the group that continued treatment and the group that ended treatment. And what we could see was a higher percentage in the group that continued treatment really got central stimulants. So maybe this supports that they improve and they really benefit from medication. What we also did was to try to look at all of them that had ended treatment. Was there any difference between the ones that got central stimulants and the ones that did not get central stimulants? What we could see was, this was kind of surprising, that the group that got central stimulants were older, had a higher mean age. I would guess actually that the ones that really, the severe cases, they come early to services. They do not introduce themselves at counts when they are 13. Number of diagnoses, no difference. Number of psychosocial stressors, higher in the group that did not get central stimulants. So maybe in this group, people think there are more factors that really are affecting the child.
Could you see if there's any comorbidity with conduct problems in that group?
No, we didn't look at that, but that's absolutely possible to do. We are not that good on actually putting the conduct disorder diagnosis. It's we have huge problems in Sweden trying to cope with that, because it's very it gets emotional, I think, for many clinicians to actually really pinpoint that, and also ODD the same way. So
on Monday, one of the clinicians in London said exactly the same thing.
So it's and I think when I worked with this thesis the last months, I just felt, let's stop doing everything and only focus on kids with conduct disorder, because that's such a strong predictor for so many bad outcomes in the future, and we do not have good treatment models either for conduct disorders, so it's not well taken care of. No difference between number of visits, and no difference between the delta CGAS either. What you can see here, CGAS at baseline was actually a little higher in the group that received central stimulants. Also surprising. You could imagine that the kids that really got central stimulants actually had a lower level of functioning. But here is something where we really could learn. And this is when we looked at the treatment interventions. What we can see is that the children that receive central stimulants, they receive less psychotherapy to the family and to the parents. And that's important information to us as clinicians, that we cannot withdraw psychotherapeutic intervention that's really supported in clinical guidelines and has effect to kids because they get central stimulants. So as you can see, both guidance to parents, family therapy and family counseling was more than the double of the group that did not receive central stimulants that got these interventions. So that's really a take-home message to our services. Are we following the guidelines? Are we doing the right thing? So what we could see was that CGAS at baseline was lower compared to clinical trials. Our patients are more impaired. The size of improvement was lower compared to clinical trials, and I think one explanation is because we have excluded all the kids that still are in treatment. And patients that received central stimulants received less psychotherapy to family and parents, and less parent training, and this differs from clinical trials.
Did you check also how they administered how often they changed the medication? Because I remember, I think it's Professor Jensen talking about one of the reasons why you get less effective stimulants in clinical practice as opposed to trials is because in clinical practice people don't administer it well. And particularly they don't change. They give the medication, they just stick with it, and actually it's as much about, you've got to modify as the child goes along.
That's a really good comment, and from 2011 our clinical database, Pastille, is interacting with our electronic chart system, so we will know the dosage and the changes. But these data, we only know if they got it or not.
So one hypothesis might be that the more they change it, the better.
Absolutely. That would be an interesting thing to go in and look at, because now we have much more data, and we know the dosage level, and we also know if they change it up and down. So
I think the NTA study showed that, didn't it? That it was much more effective with really frequent appointments, really titrating the dose rather than just you start and you sort of leave them. So I think that's what we do in clinical practice.
Because I think the treatment as usual group, intervention group in the MTA study, 65% of them received central stimulants. So it's but still didn't improve
because they weren't doing that very close
yes.
titration.
That's interesting. And routinely collected CGAS must include regular assessments during ongoing treatment. That's also important for us. That's one of the usage we could have from all these data. The last thing I'm going to talk a little about is actually the biggest surprise, and I think that was really interesting for me to look into. In 2006, when I had one of my first training seminars, I had a PowerPoint presentation, and I was talking, what can you use CGAS for? Different questions, and I epidemiological studies and clinical trials and looking at treatment outcome. And then the last point I had, prediction, question mark. And so this is really nice that we collaborated with the national registers that we have in Sweden. This paper is submitted but not yet published, and the aim here was to see whether CGAS ratings can predict future outcomes. And the future outcomes we looked at was criminal conviction, mental health disorders, suicide attempts, substance misuse, and accidents. So we could gather 4,876 patients, and it's from the same period of time, July 2006 to December 2009. And they must have a treatment period longer than 1 month. And again, we used the clinical database Pastille, the CGAS at intake and at end of treatment. In this study, we do not look at the delta CGAS, only intake and end of treatment. Now, we did a follow-up, and the follow-up time was an average of 1.5 years. And we linked the data to national registers, both the patient register and also the crime register. So, what did we do? Well, we tried to divide all the patients into 2 groups. And we looked at the ones that had a CGAS rating of 60 or lower compared to the ones that had above 60. Now, if you remember the cutoffs, 71 and above is supposed to be normal functioning, and 61 to 70 is a probable clinical case. Now, we have lots of patients that actually leave services when they have CGAS 60 or lower. from different reasons. What we could see is that the group with CGAS 60 or lower had an increased risk of all of these negative outcomes. And here we have the unadjusted hazard ratio. If we look at criminality, well, I guess many of you will think that, of course, it must be ADHD or conduct disorder that really explains this. If you have those diagnoses during childhood, it's an increased risk of criminality when you become adult. But when we adjusted for the diagnosis during the child psychiatric period, there was still an increased risk of criminality, of bipolar disorder, and borderline personality disorder. So we could actually see that the functioning in itself, not depending on the diagnosis, is a risk factor. So it's actually a warning signal when kids do not function. So CGAS ratings at end of treatment, but not at intake. We did the same analysis for the intake values, provide specific information about the outcome of child psychiatric patients. So intensified follow-up might be needed for adolescents with an end of treatment CGAS score of 60 or less. And I think one special group where this is important to think about is when kids go into adulthood. If we have children that are in camps and need adult psychiatry, if they have a low level of functioning, you should really take them into your arms and carry them all the way over to adult psychiatric services and really get a good referral, so they will really get a clinician where they can continue their treatment. CGAS, if we summarize, is a reliable and valid measure. It's suitable as routinely collected variable in large clinical settings. It's a useful tool. You can evaluate effectiveness and outcome of child psychiatric treatment. You can also look at predictions of negative outcomes. And the training effect is still a question mark. We need to work more on that. Future evaluation studies need randomized control groups to control for unspecific learning effects. And that is what we're going to start in March and hopefully get results in the fall to look more into this. So if anyone's interested, I'll leave 2 books here. This is almost like I think the only textbook on CGAS, and I guess it's how can anyone go into CGAS this far? Well, I don't know. I did. And I'd like to thank, there's been lots of people working around this, my 2 supervisors, Mikael Landén and Carl-Johan Sundberg. They have a special background. Mikael Landén is a professor in adult psychiatry, but he thought this was so much fun. And Carl-Johan Sundberg is a professor in sports physiology, and that reflects my background as a PE teacher. And then we have epidemiologists and a statistician and different people working at the camps. Any questions?
Lots of interventions very focused on symptoms rather than functioning. Or the way we're asked to record what we do is, does the symptom get better? And I was thinking about adults with psychotic illness and auditory hallucinations and great drive from adults can't just get rid of the voices, and the move now to accept that some people just want to be able to live with their voices and function better, and it just made me think about that.
Yeah, that's a
Are
good
we focusing
point.
on the wrong thing?
And sometimes, like depressed adolescent, usually the recovery of the level of functioning comes later than when the symptoms get better. So I think it's important that we don't stop when kids get happy again. They really need to get back to school and back into their activities and to function with friends and at home. So sometimes, actually, I think maybe we also can motivate families and patients more if it's more function focused, because it's really, that's what you have in front of you. I can't go to school.
That's what causes the stress in the parents, isn't it? The stress in the parents is that functioning.
Yeah, sure.
I just want to ask whether you'd had any experience of whether people share the CGAS scores with clients and discuss them, and use them to discuss them, and do it collaboratively with clients what our scores are.
No, they don't, because the end of the CGAS rating at the end, then the patient has left their treatment. And that's a really good point, because I think we should try to encourage clinicians to really talk functioning with the child and the family.
And do you have any evidence that people do talk about possibilities of functioning?
Yes, I really do. I have some really good examples. After I've been there and had the training seminar, there are some units that have been so well structured. So they rate one case every week, and they do it together in a team conference. And many times they've come back to me and said, "Can't you come another time and discuss diagnostic evaluations?" Because I try to focus that it's not the rating, the number, that's not the most important thing. It's the process, it's the discussion, it's the thinking about the child's functioning. That's why we're doing this. And when people start to talk about functioning, they get more interested in diagnostic evaluations. And CGAS, it's not a separate evaluation, it's really a correlation to the diagnostic evaluation.
And has there been any work done on how good clinicians are at predicting what the function will be at the end? So, you know, just using CGAS and saying, okay, well, if you were to predict what's the ultimate function you think this young person will get given where they are now?
That would be really interesting. No, I've never seen that. Never. And I
encourage you to think
that's good, because a lot of families are disappointed after cancer treatment. And I think one of the reasons is that we do not talk about what is reasonable to expect. And sometimes during treatment, other problems pop up, and we do not rephrase what is the goal with the treatment. So it would be good to think about what is actually this kid's superior level of functioning. Now, all of you here are of course on the level 100, but I mean, most people are.
I've just got a clinical point we noticed in our service, because we use CGAS and other things, is that young women with anorexia nervosa can score really highly.
Yes. Good.
So, you know, you have to look, just shows you have to look at everything, don't you? Symptoms and functioning. Yesterday,
when I had the CGAS seminar, I talked about how do you identify a clinical case. And I have four items. And one is the diagnostic criteria and symptoms. But we know that tons of kids fulfill diagnostic criteria, but they don't need our services. And if you add functioning, well, the group will decrease. But then you have some groups, and anorectic girls is a good example. And they can have they can actually suffer, but they perform fantastic results. And if we do not, I think that's such a good example when you cannot use a cutoff to decide where to intervene with services, because we know if we come in early, the treatment period will be shorter. So it's really good to come in early in a family with an anorexia that is just on top of her performance before she will really get very ill and affected by her. And the fourth one is when the family and the network is so distressed, and that can also be the case with anorectic girls. I mean, mothers and fathers, they running around with cookies and food and everything, and the anorectic girl, she doesn't matter, and everyone is just exhausted, and they just see her lose weight. And that's also a reason to actually identify her as a clinical case, even though she have a functioning level of 82. And she scores fantastic tests in school and takes care of all her friends.
What's interesting then is, of course, you might be aiming for her to have a lower level of functioning. as an outcome
Yeah.
that is healthier.
Absolutely, yes, that would be more healthy. So that's a good. Also, OCD can kind of be tricky because it's they will be affected in a very isolated area in the beginning, maybe at home, but it's not affecting school functioning and friends yet. But we know as a clinician that it will in the future. So.
Just while you're talking about different exceptions, could you just mention about learning disability and how that fits into this? Because I think it's important for people to.
It's good to, if you think about 71 up to 100, and that's considered normal, if you have children that need special education, actually they can score 71 and above. So if you need to go to special ed or in a special class, or you need many special arrangements around school functioning, well, you're not above 70. So mental retardation, actually, top scores would be 70 because you're not going into a regular class system if you have mental retardation. So it's important to think about CGAS. It's not 100 is not the individual 100. 100 is the super duper kid in a school here in Hampstead that has straight A's and socializing, lots of friends, and of course maybe I haven't talked about that at all, but cultural issues will really affect CGAS ratings as well.
Thank you for the most fantastically lucid and interesting talk.
Thank you.
Thank you very much.
Okay.